let's briefly go through, and then if there's time, we'll talk about something else. So this is, as I always say, it's more of a revision session. And I mean, most of the topics that we discussed last week, and I think part of last 2 weeks, were all internal medicine, one in quote topics. But with CVAs, we discussed that not so long ago. So I expect that it should be fresh in our minds. And I am hoping that we've been reading around it since we might get a question from there on Friday. I'm hoping that we are CVA champions now. Anyways, so we'll just go through, we'll just look at a summary, and then we'll touch on the management aspects. Okay. So once we are talking about CVAs or strokes in general, two main things pop up in our minds. It's either there is some sort of poor blood flow going to some part of the brain due to one, a blockage, or two, rupture of the blood vessel. Okay, so once we mention CVA, all right, okay, then we know, okay, we are talking about the brain. And we are also talking about the fact that there's a problem where some part of the brain isn't receiving enough oxygen, and this problem is basically due to a vascular cause. In general, we know that there are two main types. We have ischemic type or infarctive type, and then we have the hemorrhagic type. In the clinical setting, you will be coming into contact with this patient, and because their managements vary, it is very, very important that as a clinician, you are able to make that distinction clearly, because if you fail to make the distinction, you will rather push your patient further. For instance, if a patient has an hemorrhagic stroke and per your management, you have forgotten that hemorrhagic strokes mean that there's a bleed somewhere in the brain. So you go ahead and then you give an anticoagulant because you're thinking, oh, the patient is bedridden, so patients will develop a clot. Let me give an anticoagulant. An erratic administration of anticoagulants or even antiplatelets, you end up killing your patients because you fail to distinguish the hemorrhagic stroke from an infarctive stroke, or maybe you even forgot. You end up killing your patients because your patients will bleed more into the brain. Okay, so knowing the kind of stroke you are managing is very, very important. In the emergency setting, once the patient is rushed in, patients will come, they'll basically rush the patient in. Most of the time, there's some form of neurological deficit. Sometimes the patients will come in unconscious, and when they are resuscitated or they wake up in quotes, they realize that, okay, a part of the body isn't functioning well. And that's what we call the focal neurological deficit. In terms of neurology, a part of the body isn't functioning well. So they realize that, all right, okay, I'm not able to lift this, my hand. I can lift it, but it's not like the way it used to be and whatnot. Okay, so that is what we mean by focal neurological deficit. So sometimes they would come to the ER already with a focal neurological deficit. Other times they will bring the patient in unconscious or semi-conscious, especially if you're looking at the hemorrhagic type where most of the time blood pressures can go so high, and because of this increased blood pressure, the vessel just ruptures. Okay, at that point, patients can go unconscious. And then when they come to you, you are thinking, okay, what could this be and what not? Okay, but most of the time, if you know the person's characteristics in terms of the age, right? And then you also know that, all right, this patient here, you are accessing the patient and you've realized that the BPs are very high and this patient is unconscious, that should give you an idea of what you might be dealing with. Because as you know, looking at stroke, we know that high blood pressure is a risk factor for stroke. Okay. All right. So making that distinction is clear. Once they come to you in the emergency setting, your own is to, one, first of all, resuscitate the patient. Two, make an appropriate diagnosis, know what we are dealing with. Because without that, you basically fail in the patient's management. So resuscitation, as we've been talking about the past few weeks, we are looking at airway of the patient, we are looking at the breathing, we are looking at the circulation of the patient. And this will be dependent on, one, your physical examination findings, and two, the vitals that you pick up on examination. Of course, if a patient is brought in unconscious and you realize that the SpO2 is dropping, it prompts you and tells you that there's something wrong with the airway. You don't just go and give oxygen to the patient. You always go by the rule, assess and manage, assess and manage. So before you even think of delivering oxygen to the patient, you need to assess the airway, right? The nose coming all the way to pharynx, going all the way. You need to try and assess the airway. For all you know, once the blood vessel ruptured, the patient lost consciousness. And when you lose consciousness, there's the possibility that secretions can move to your airway. Ideally, if you're unconscious, you are able to control that action from happening. You're able to prevent it from happening. Now, once you are unconscious, it's easy for you to aspirate. And once you aspirate, the secretions, whatnot, airway becomes blocked, and then you are in trouble. So you can have a patient who has a CVA, but then it's actually the problematic airway or the fact that airway has been impeded is what is going to lead to the demise of the patient. So you always assess the airway. Then you look at the breathing, which you've always talked about, and then also circulation. So circulation here, your vitals will point you to whether blood pressure is so high or blood pressure is within a normal range. And then you control it accordingly, depending on what you want to achieve. Okay, so we'll come there. But we all know that when you're managing stroke and a patient comes to you and the BP is so high, even though you are focused on bringing the BP down, the decrease of the BP shouldn't be so drastic. Because if you try decreasing the BP and it's so drastic, then you are going to have some form of hypoperfusion, because you're going to drop the blood pressures, and then the brain is even going to suffer more because of hypoperfusion to the brain. Of course, other vital organs will also suffer. So in stroke management, you always need to assess the BP. Most of the time, if you're looking at an infarctive stroke, the BPs would usually not be so high as compared to hemorrhagic strokes. Okay. So if you have a case study, you need to be looking out for, all right, okay, how high is the blood pressure? Oh, wow, blood pressure is quite high. Okay, symptoms are showing that this is stroke, but this high blood pressure, it is possible that this is a hemorrhagic stroke. In the clinical settings, it's also like that. Patient comes, they think this is a stroke. You haven't done a head CT scan yet, you can't tell, but with your vitals, you can hazard a guess and say, all right, okay, the way this blood pressure is so high, it is likely that this would be a hemorrhagic stroke, because they're having blood pressures above 240 over 120. It's possible this patient has ruptured a blood vessel. Okay, all right, okay, this blood pressure is not so high, it's about 140, 100, but I still think the patient has a stroke. I think this is an infarctive stroke. I think there's something blocking the blood vessel. So this is how you're supposed to be thinking through your cases that you see. It's not always the case, right? It's not always the case, because you can actually have a patient who comes in, BPs are high, and you think, oh, this is a hemorrhagic stroke. You won't wait for your investigations, and then you start managing as such, and you might have issues. Okay, or you might get a patient whose BPs aren't so high, which is even more dangerous. You say, oh, this is an infarctive stroke. Then you start throwing in antiplatelet and anticoagulant. Imaging comes back and it tells you that there's a bleed. You've killed the patient. So you need to be careful. For instance, those in 400, I remember I gave them a question on CVA, and the vitals, the BP was high. So if you see it at first sight, you say, oh, all right, this is a hemorrhagic stroke because, the blood pressure is quite high. But then when you take your time and you read through the question, the main thing, the gold standard for making a diagnosis or differentiating hemorrhagic from infarctive stroke is to do a head CT scan, right? That is the gold standard, not the vitals. The vitals, the blood pressure and whatnot will just guide you. It would help you make a guess, an educated guess. But the gold standard is the CT scan. So they fail to see that, oh, in that question, the CT scan said that there was an hypodense lesion, which we all know that once we are talking about hypodense, we are thinking that, all right, okay, this is likely to be, but this is an hypodense lesion, which is likely to be an infarctive stroke. And then this is a hyperdense lesion. So a hypodense lesion and then a hyperdense lesion, right? So the hyperdense looks whiter. Usually when you bleed into the head, this is what you get, okay? And then if there's an infarct or you have an ischemic injury, it looks darker. Okay, sometimes you do a CT scan and it comes back and it's like this. A patient isn't really showing signs for you to say that this is a stroke because blood pressures are fine and whatnot. Okay, maybe the patient has some form of neurological deficit. This can also be a mass. It can be that the patient has a tumor in the head. Okay, but here we are talking about strokes. So if you do a head CT scan and you have an image like this in a patient who has a stroke, then you know that you are dealing with a hemorrhagic stroke, and this is called a hyperdense lesion. And if you get a darker one, then you know you are dealing with a ischemic stroke or an infarctive stroke. This is a hypodense lesion. So you need to pay attention to the whole question, not just some part of the question. And with this, the people who paid attention to the final statement there, that the head CT scan that was done showed a hypodense lesion. So in that question, it was hypodense. So they were like, oh, okay, they didn't really pay attention to it. Once BPs were high, they just went straight. And once you get the diagnosis wrong, if you say this, it's a hemorrhagic stroke, well, because you think BPs are high, and it so happens that it's an infarctive stroke because the head CT scan showed a hypodense lesion, you are going to manage the case as a hemorrhagic stroke, and that will be wrong. Okay, so you should be able to distinguish one from the other. For instance, if you have an infarctive stroke or ischemic stroke and you go ahead and you manage it as a hemorrhagic stroke, you kill the patient. You are not supposed to pass that question. If you manage an infarctive stroke as a hemorrhagic stroke, it means you kill the patient. Ideally, you're even supposed to get 0 when it comes to management because you've killed the patient. Okay, so you need to pay close attention to it.
Dr. Minta, I have a question.
Yes, please.
Yeah, so if the CT scan is not readily available, for it to even show if it's infected or it's a hemorrhagic.
What do we do?
Where do you start from? Yes.
Yes, so you start from your ABCs. That is the best point to start from. So it's not like you're not going to do anything for the patient. You are going to do something. So your ABCs, and as part of your ABCs, you're checking vitals. So it might become apparent that BP is so high that you need to probably give some dose of hydralazine IV to just bring it down slowly. Or maybe you can decide to do a cocktail of your orals to just bring it down gradually. Okay, so you can start with those things. All right. And then in CVAs, once you are suspecting a CVA, or in any patients you are suspecting a focal neurological deficit, or any patient who develops some form of unconsciousness, any patient who develops a seizure, getting a head CT scan done is imperative. It's emergent. You need a head CT scan to know the way forward. Like, you need to do it. And we are gone past those times where we'd say, oh, maybe patients can afford, or oh, let's manage. I'm sure it's a stroke. How would you know it's a stroke? And I mean, these were the reasons why we're losing people who had strokes. We can all attest to the fact that when you were young, you hear, oh, this man had a stroke and he died. But now the mortality is not so bad because of the advent of imaging. We are able to pick up the exact cause of the stroke, and we are able to pick up the exact type of the stroke, and you are able to manage accordingly. Okay, so once you resuscitate and you stabilize your patient, the next thing you are doing is you are moving the patient to this imaging center in your facility. If you don't have one, but your facility can handle stroke patients, you are moving the patient to the nearest imaging center. If you think your facility cannot handle the stroke, once you resuscitate the patient and you put the oxygen on for the patient, you are moving straight to a bigger facility where they would manage the case. Once you resuscitate the patient and you feel the patient is good, vitals are stable, what most facilities do now is, before they move to the bigger facilities like Colibu 37, Rage, UGMC, and whatnot, they would pass by, correct imaging centers and have a head CT scan done before they get to the treatment center, because definitely, if it wasn't important, they wouldn't do that. Yes, so you will need to get that done, right? And then after that, we know what the patient has. Then the actual management for what the patient has can now commence. So you stabilize, control vitals properly, your oxygen is on, you are going to get your imaging study done, and then you decide on if you are managing as an infarctive stroke or if you are managing as a hemorrhagic stroke. Any questions?
Sir, please, I have a question.
Yes, please.
Okay, so will you wait for the person to be stable after the resuscitation and whatnot before you do the head CT?
Yes, you can't. It's very important that your patient is stable before you do imaging. And that is why your primary survey and management, or your initial resuscitation, you don't have imaging studies as part of it. It is secondary. The most important thing is your patient has to be stable. Whether the patient has hemorrhagic stroke or an ischemic stroke, you need your patient to be stable before you put the patient in that machine. Because if your patient is not stable, your patient will die in a head CT scan machine, and then they will take you to court. They will ask you when you get there. Most of the time, the lawyers who come are also doctors. So they will ask you that, Chief, what is the standard of practice? Then you say, oh, you resuscitate and you stabilize, and then afterwards you do imaging, because imaging is very important, blah, 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 blah. Then they'll ask you, is that what you did? Then you say yes. You say, oh, how come the patient died in a CT scan machine? It means you didn't stabilize properly. That's a malpractice. So you need to stabilize and make sure that the vitals and everything are on point. If you are referring because you don't have managing stroke patients, everything is time bound. So I do understand your concern for this before starting management.
Exactly.
But know that the resuscitation forms an important aspect of your management for the patient. I'll tell you why. If a patient has an infarctive stroke, the only different thing you are going to do in addition to the resuscitation is giving your antiplatelets and your anticoagulants, right? Which, of course, is good. Sometimes you can go ahead and then you can give your tissue plasminogen activator, which is also life-saving. But all this is dependent on you knowing whether what you are handling is a hemorrhage of that. And before you get to know that, the patient has to be stable. So if your patient is not stable enough, you don't venture trying to moving on to the next stage of management, because this is also an important stage in the management. It's sad that our healthcare system is like that, but when you go to developed countries, and that is what they are trying to do at the facility I work, the emergency department is in the same building as the imaging center, because they know that when cases come to the emergency, your first thing is to resuscitate, stabilize, and because of higher standards in clinical care now, you try to make a diagnosis. Imaging will definitely be part. So it gives you a faster access to imaging, and we just push you there and you have your head CT scan done if we are looking at a stroke. Okay, so it's very, very, very important that you do your imaging, but then making sure your patient is fit for the imaging is also important, because even if you call the imaging people, they will ask you, what are the vitals? You get it? So if your BPs are over the roof, or you say, oh, the patient is in respiratory distress, they'll just raise an eyebrow and you want to come and put in the machine. It's quite challenging. It's quite challenging when it comes to that, because you can actually lose your patient. So you always have to resuscitate, stabilize the patient, and then call the imaging center. If you are referring, you call where you are referring to so that they get ready for you. If you are going to stop by an imaging center, you call them before. So even before you get there, they prepare the machine, because you can't get there and they'll tell you there's a queue or there's someone in the machine. So they would be ready for you. There'll be oxygen there. You get there, patient is moved out of the vehicle, oxygen on, straight to the imaging center, back, and then straight to the caregiving center. So everything is supposed to be timely, and that's what they do outside. Same for managing myocardial infarctions and whatnot. And that's why someone can get an MI, and then within a twinkle of an eye, they've diagnosed and they've managed, and then maybe the person is getting a bypass or graft or something. But in Ghana, it's quite difficult, and we have to rely on so many things. But we are teaching you the standard of care, so please follow the standard.
Okay, so thank you.
So, Dr. Minta, what's the time frame we should be looking at? The time frame from the time we decide to stabilize to the time that the patient gets to have the head CT done.
Okay.
What time frames working around?
Yeah, excellent question. So we always say that as soon as possible. That is what we always say. Okay, we always say that as soon as possible, you should get it done. If you're able to, you get a patient who has a stroke and you're able to resuscitate, within 30 minutes, you'll be able to resuscitate your patient. Okay, the first 30 minutes, patient comes is very, very vital. And then we also have golden hours for administering some of the medications, which we'll be talking about. But once the patient comes, you should be able to resuscitate the patient within that first 30 minutes to 1 hour. If possible, the patient has gotten a head CT scan done. These are the ideal situations. Sometimes the patient is rushed in and the patient is already awake and the patient just has some form of hemiplegia or hemiparesis. You check the vitals there and then, oh, this is okay. Just let's set some IV fluids on her. You move straight to the imaging center because the patient is awake. So it is variable, but we say that it has to be done as soon as possible. I know that in Ghana, sometimes 24 hours, we haven't even done a head CT scan, and then we'll be basing our diagnosis on suspicion. And I mean, before I moved to UGMC, I've worked in other government facilities that was the norm. Yeah, because you even need an ambulance to come and get a patient and send a patient to an imaging center. If you so happen to be outside Accra or outside a big city, that's even a challenge because they have to move you in an ambulance to a nearby city and all that. So usually with those ones, we hold on to medications that we know can impact your management negatively if it so happens that that is not the diagnosis. We hold on to it. And that has been the practice that I was exposed to, back then, before I moved to a place where you have easy access to imaging. Once you are at the OPD or you are at a locum site and the patient comes and then it's a stroke, yours is to stabilize. Make sure that you kept the vitals under control. Make call for the ambulance to come. Wait, contact your imaging center for them to be ready for you. So sometimes you do the imaging even the next day, but that won't kill the patient. That will only delay some of the important things that you are supposed to do. But if you've resuscitated your patient and you're keeping an eye on the vitals, you are basically buying time. But as soon as possible, you need to get it done early. Okay.
All right, though. Thank you.
Welcome. Any questions?
Hello, sir.
Yes, please.
Please, with TIA,
Yes.
I want to know the immediate management before you refer.
If it's a TIA, you don't need to refer. Unless you find yourself in a very small corner. But the thing is, if you refer a case of a TIA, the TIA, you remember what TIA is? It will basically resolve within 24 hours. TIA is just the warning. TIA, transient ischemic. Yes, let me open it for you. Yes, so you have a transient ischemic attack, and we have different features, and we are saying that there's a focal neurological deficit, and this focal neurological deficit within 24 hours will disappear. Okay, so once the case comes to you and there's a focal neurological deficit, you as a clinician won't know that this is a TIA unless that 24-hour comes on, or maybe the patient came with some hemiparesis or hemiplegia, and whilst the patient is on admission and then you are thinking this is a stroke, miraculously it disappears and the patient gets up and goes to the washroom, walk around, doctor, I'm fine, I want to go home. That is when you get to know that it's a TIA. Another way of getting to know that it's a TIA is a patient who have a focal neurological deficit, and you as a clinician thinking, oh, this could be a stroke. Quickly, let me do a head CT scan. And if you are lucky and you are in a place where you can do a head CT scan very fast, the head CT scan will come back and basically everything will be fine. Right. Nothing like a bleed, nothing like a clot. It will look perfectly normal. And that is where you come out and say, oh, okay, it doesn't look like you are bleeding. It doesn't look like you have a clot in the brain. The head CT scan is basically fine. Let's wait and let's see. Usually in less than 24 hours, you feel better. And it's like magic. It works every time. It works every time. If it doesn't work, it means that you need to repeat your head CT scan. Probably there was some form of ischemia somewhere. Usually if there's a bleed, you can't miss it. The ischemias can be a little bit tricky if it's small and tiny. Because of the way it looks black, you might not see it, right? Because if the gray matter, it's a little bit dark and it's in the area of the gray matter, you might not see it well. But if it is white as a hemorrhagic stroke, clearly you see it. So TIAs, you can manage on your own if you are sure it's a TIA. TIAs are warnings. You need to find out what caused the TIA. So you need to do your investigations. That's where your lipid profile comes in, because you want to know the person's, how high the lipid or how deranged the lipid profile is. Because definitely if a patient has a TIA, you are thinking of starting your statins for the patient, okay? So you want to know the dose, how bad the TIA is, your lipid profile is, will prompt you that, okay, let me hit high, let me do a high dose statin, or let me just do a moderate dose, okay? Also, you would give your patient aspirin, clopidogrel. That is where, that is what you do when you are handling a TIA. If it's a TIA, you can actually manage, unless you are in a place where maybe the clinic runs till 5 and the patient comes in, you're not sure if it's a stroke or a TIA, you need to refer a patient. Okay. Maybe are you okay?
Thank you very much. Thank you very much.
Yes, welcome. All right. So when you're looking at the infarctive stroke or the blockage, remember we said that you can have a cerebral infarction, can have a brainstem infarction. To our image here. So this is the brain. So you can have an infarction here, okay? Or then you can have an infarction here, that is the brainstem. And the way the patient would present will tell you that, all right, this is a cerebral infarction, or this is a brainstem infarction, okay? So it's very, very essential that you look at the presentation of the patient. So if you go through the slides, you see how cerebral infarction would present, and then you see the different syndromes in brainstem infarction. Okay, so depending on where the damage is, for instance, if the reticular activation system is damaged or is infected, this is the part that basically controls sleep. You know, so if it goes off, then it means you're going to be in a very, very deep sleep. So that's why you would have coma. Okay. If you have a lateral medullary syndrome, then you are going to have contralateral deficits in pain and temperature management, and ipsilateral cerebellar sign. Contralateral means that if the damage is on the left, you are going to have symptoms on the right. Okay, and ipsilateral is the other way around. And all this is because of the concept of decassation that we talked about a couple of weeks ago. And it's also locked in syndromes, pseudobulbar palsy. All these are syndromes under brainstem infarction. So in your clinical practice, you need to pay close attention to whatever is happening. And there are simple things that you shouldn't miss. For instance, if a patient is showing hemiplegia or hemiparesis on the left, if you are requesting your CT scan, you know that the damage is going to be at the right side of the brain. Okay, so these are things that you shouldn't miss. If you go for an exam or a viva and they bring a head CT scan out and then the problem is at the right side, the examiner will ask you that how will the patient present? Then you can go ahead and say the patient is going to have a contralateral, or the patient is going to have issues on the left side, maybe a hemiplegia or hemiparesis on the left side. And the specialist knows that, all right, you know what you're talking about. So as I said, your resuscitation, stabilization is very important, okay? And ideally, you need to admit to a facility that can handle stroke, and you have access to all other specialties like the neurologists, like the physiotherapists. You have nurses who have been trained to handle the stroke units. You know, you have a dietitian. All these people play an important role in the management of stroke. But for you in the emergency setting, once it comes to you want to resuscitate, assess airway, you manage, you know, you check if the patient can swallow or not. Because if there's a stroke, sometimes it affects the swallowing. So it can affect the way you are going to deliver your medications. Because if the patient can't swallow, you don't waste time giving the patient tablets to swallow. You need to pass an NG tube for the patient, because your patient has to be fed and you can pass medications through the NG tube. If your patient can't swallow, you can't say you're going to give IVs throughout. No. So an NG tube is important. So you assess swallowing and then you see if your patient can swallow or not. Okay. Usually we use a small syringe to draw some water. We put it in at the side of the patient's mouth and then we try to push. And we see if the patient cannot swallow, you see that the water is actually drooling and coming out. The patient can swallow. Once you do it, it doesn't come out, it just goes and you see the patient swallowing. You need to check vitals. It's very important. You can also have a patient coming to you. Clearly, this will be a stroke. But then if you just be there and you lose the patient because you fail to check the patient's random blood sugar, patients can come with a stroke, but because the patient can't talk, the patient can tell you that I am hungry or whatnot. You realize that blood sugar would be dropping and then you lose your patient. So always, if you're checking your BP, your SpO2, your temperature, your respiratory rate, your pulse rate, don't forget to check your RBS. It's very essential. In many emergency settings, you are lucky. Before the patient gets onto the bed, they would have checked for you, but you always have to ask before you even touch the patient, what is the RBS of the patient? You don't want to go and put normal saline on a patient who you don't know his or her RBS, a stroke patient, you don't know the RBS, you go and put normal saline. What if the patient's sugar before they rushed him in or her in was about 4 point something, and then you go infusing normal saline? By the time you realize the patient has gone into hypo, so you need to ask. It's very essential. You need to make sure your patient is well clothed so that the patient, doesn't develop any form of hypothermia. At the same time, you have to make sure that the patient's temperature isn't so high, okay? And then once you ruled out that there's no bleed in the head, you can go ahead and start a tissue plasminogen activator and your antiplatelets as well. Those are the key things. So tissue plasminogen activator, antiplatelet, and anticoagulant. Some studies are saying that we shouldn't give others. There's still a gray area, but you can go ahead and then give a prophylactic dose. It's safe, okay, to just give a prophylactic dose. If you're dealing with a hemorrhagic stroke, you don't even think about that at all. Then, of course, you discharge your patient on an antiplatelet. You can go ahead and then you put your patient on some statins as well. It's very, very essential, especially if you are thinking that this is an infarction, because most of the time, infarctive strokes, as I said, they tend to have an elevated cholesterol level. So you need to think about that as well. Any questions so far, please? Okay. Of course, there's also the role for surgery. You can remove the clots, or you can do a bypass, and you can do an angioplasty for the patient, or you can go in and then remove the clots. If you're looking at a patient who has an infarctive stroke, one of the investigations that we do is carotid artery Doppler, and we want to assess the blood flow in the carotids, okay? Because if most of the time you do a carotid artery Doppler, it comes and then it tells you that there's poor flow in the carotid artery. That tells you that there's some sort of obstruction, there's some sort of plaque that has formed in the carotid artery. So your carotid artery Doppler is very, very essential if you're thinking this is an infarctive stroke, because you need to know where the problem is. If the clots or the plaque is sitting in the carotid artery and you manage this patient, the stroke, the patient can develop another stroke again because you haven't really dealt with the problem. Okay, the plaque is still sitting in the carotid artery, you haven't dealt with the problem. So you need a Doppler for that, and it's something that we do. If a patient has a TIA, one of the investigations we do is a carotid artery Doppler, because, as I said, TIAs are warnings. It tells you that something is about to happen. So let's look for whatever is about to happen. So you need to do a carotid artery Doppler. Once you find a plaque sitting there, you can do what we call an internal carotid end atherectomy, where you are actually going to sort out whatever is in there. And then sometimes you can do a percutaneous transluminal angioplasty. You stent the blood vessel, so that just like what the image we showed when we're looking at myocardial infarction, you put a stent in the blood vessels to open it up. Once you have a bleed, some rules. You need to make sure you're following rules. And that is even the main reason why you are doing your head CT scan, so that you don't go and give a patient who is bleeding antiplatelet or anticoagulant, right? So once you have a bleed, which you've confirmed with the head CT scan, your own is to control the vitals, basically. Make sure you don't drop the BP too fast, okay? So confirm with the head CT, after you've resuscitated, control your vitals, basically, and then you go ahead, you are giving your patient the infusions you are supposed to give, just to make sure that your patient is getting some nourishment and whatnot. You avoid anticoagulant at all costs. You avoid antiplatelet at all costs. You don't give this patient tissue plasminogen activator because they will bleed more. And then the next thing you do is to think of referring to a place where they have a neurosurgeon, okay? Because there's a possibility that they can go in there and then evacuate the bleed that, is going on. They can go in and then stop the bleed and then evacuate the blood clots for the patient to be fine. There's that possibility. Okay, so gone were the days where if you have a hemorrhagic stroke, they're like, oh, this one, let's leave him for God. Let's just hope that the bleed and the hemorrhage actually resolve. You can't do much. Gone were those days. You need to give the patient a chance, right? So, initially it's just about ABC, giving your fluids and then just doing watchful waiting and praying that your patient survives. Sometimes we come to the ward and we know this one, the prognosis is very bad, but people have survived after hemorrhagic strokes if they are able to get, or when they're able to get access to a neurosurgeon consult at a faster pace. Okay, so you think of referring. If you have a patient who you think this has a bleed there, you don't know where to send to, just bring to UGMC. We have a very good neurosurgeon. He does things like that, so they'll sort it out. Of course, it wouldn't work for every patient because surgery comes with its own complications, but the patient has a better chance of survival than not doing nothing in most cases. Okay. If a patient comes to you and the patient gives you a history suggestive of a subarachnoid hemorrhage, and usually the classic thing that will stand out is they will tell you they have very, very severe headaches, and sometimes they have signs of meningism because they are bleeding in there, so they might have this meningeal signs that you tend to see, like the neck stiffness and whatnot. Okay, you know that, all right, okay, this patient doesn't have a temperature and this was acute. I don't think that this is meningitis because the patient hasn't traveled, hasn't been exposed to anyone, doesn't have any other symptoms. It's just severe headache, blood pressure is high. Maybe the patient has ruptured some aneurysm there, or some arteriovenous malformation has broken in the brain, so the patient is bleeding in the subarachnoid space. They will come and they'll tell you they have really, really, really bad headaches, okay? And then you should be able to make that diagnosis and manage accordingly. Main thing is you're giving nimodipine to the patient, and you need to start within 4 days of the bleed. They are given 60 milligram 4 to 6 hourly for about 21 days, okay? And then, of course, once there's a bleed in there, you can think of controlling the intracranial pressure and regulating it. So IV mannitol helps. And then people are still debating about IV dexamethasone. Some people are still giving, still in the treatment guidelines. So you can go ahead and you give that to your patient. So in the management of strokes, your duty as a clinician is to be able to make a proper diagnosis of what kind of stroke we are dealing with. And then once you make that proper diagnosis, you manage properly, you manage accordingly. I say this because let's not make a mistake of administering medications that we are not supposed to administer to patients because we weren't so sure. Let's diagnose appropriately. Don't be in a rush, even though everything is about time. There's one thing that some of my colleagues always say, that especially when it's usually the infarctive stroke that you are in a hurry to give your antiplatelets and your, all those things that you want to give, tissue plasminogen activator and all that. But think of it, the stroke has already happened. If it so happens that this is a bleed, you've actually killed the patient. Resuscitate, stabilize, and get your imaging steady, and then move on to the next. It's always better that way. Okay. Any questions? Any questions, please?
Who's there?
Yes.
No question.
No question.
All right. Okay. I'm sure it's still fresh in your head, so that's good. So you just go over it. Try your hands on a couple of case studies that will come to you. You get case studies on stroke, and then you can always manage.
Okay, sir.
So let's try go over one more thing, and then you can close. So you are in the emergency room. A patient is rushed to you. The patient is, should I say, semi-conscious. The patient is not looking well. The patient looks very lethargic and very weak. Looks like this patient has been vomiting for quite some time now. You think the patient also, has some form of temperature. Patient basically doesn't look well. And then your assistants quickly prompt you and tell you that, oh, the sugar is about 28.0. What will you do as a clinician? It goes to the whole class, especially those of us doing locums. I expect that you see a lot of these cases, or you see these cases on a regular basis. Any suggestion, please?
The sugar is 28.
Yes, 28.0. Patient looks sick. Assuming you have this question in your exam, so forget about blood pressure. Patient is not looking well, patient looks sick, sugar is about 28.0. What would you do as a clinician? How would you manage this patient?
So say you start with a IV normal saline or Ringer's, and then you request for your BU and creatinine, and then you check for ketones, and then you see if there is no potassium level before you start to give the insulin.
Okay. So you said you give normal saline to the patient.
Yes.
That is one. You do B and creatinine. That is 2. And you check for ketones. That is 3. And depending on the level of insulin, if it's favorable, you go ahead and then give. Level of potassium, you go ahead and give your insulin. Okay. All right. Okay. Any other? That's a good try, though. Well done.
Okay, sir. I want to try.
Yes, please.
Okay. Sir, please, you didn't mention the BP, or the BP wasn't checked.
It's not.
No, so don't worry about blood pressure. It brought the patient to you, and then patient looks sick. Sugar is high, about 28.0. Then you ask the patient, are you diabetic? Patient says, I don't know. How will you manage the patient?
Okay, the patient is semi-conscious, right?
Yes.
Okay, so in this case, then there will be no need to check the airway and other stuff.
Why?
So because you asked the patient the question, the patient was able to respond. So it means the airway is clear enough for the patient to be able to breathe and talk. So if anything at all, then maybe we need to check the BP or check the pulse and that stuff for circulation. Then I'll give soluble insulin.
Okay. Wait, before you go on to soluble insulin, have you come into contact with a COVID patient, a moderately ill COVID patient or a severely ill COVID patient before?
No, all that I've come into contact with are
mild cases.
Yeah, mild cases, yeah.
Okay. Do you know that someone can be talking to you and when you check the SpO2, it will be around 90?
Okay, so then in this case, your question is your question did not expose that your question did not expose the BP, SpO2, and other stuff.
No. Yes. So you need to tell me everything you do for the patient. You can have questions like that. So you don't have to, should I say, think for the examiner until the examiner didn't talk about SpO2. The examiner said patient is semi-conscious and patient said not diabetic. So I won't check for airway. But that is what you said. You are answering to me like the way you write in a book. I won't check for airway.
No, not at all.
So you need to assess. That's why it's ABCs. Whenever you think that the patient is not stable, whether the patient is talking or not all unstable patients will be unconscious. Some of them will talk back to you. You need to check, assess airway. So you have to tell me that you will check vitals.
Okay.
That's why I'm like, forget about that I said, but you have to say that, okay, you check this.
Okay.
Okay.
Okay, so then let me amend my answer.
Check. Exactly.
Let me amend my answer.
Yes, please.
Okay, so you check, you do the assess and then manage. You check the airway, breathing, and then circulation. You check for the other vitals that are not mentioned, like the BP, and then if the BPs are high, you take steps to bring the BP down. And then in this case, that the sugar is high, you give your soluble insulin. At least it's a short acting, so it will bring the sugar down. And then you check for other symptoms as well. Then you do your your investigations.
Okay.
So.
Okay. All right. Okay. Both of you have done well. If I am marking, this question is on, you've gone to the exam and we've asked you and we are saying, how will you manage the patient? So that is how I put the question. I gave you a case study and then I asked you just one question. How will you manage the patient? So if I was marking your work over 20, how much would you reckon I give you?
I know that you give me like 5. I know.
Wouldn't be cry with him. Wouldn't be cry.
And Mabel, please, how much you think I'll give you?
You will give me 6 out of 10.
Okay, over 20. So meaning 12. So you mean 12 over 20. No.
Yes,
So you mean 12 over 20.
Yes.
You mean 12 over 20? All right.
Yes,
Okay.
sir.
Yeah. Well, that is manageable. That is fine. Oh, no, it's not bad. So this is how examiners will usually mark your question. If you don't kill the patient, if you don't kill the patient, know that at least you have 50%. And that is how I mark your management questions. And that is how most exam, unless the very wicked ones, they would, they want to go by the book. The person didn't write this. No. So as I always say, and it's good that this has even come up. It's an advice I'll give you. If you are answering questions, especially how will you manage the patient, and you are not sure about something, don't write it. For instance, you have made a diagnosis of hemorrhagic stroke, right? And then you are managing. Maybe you weren't even sure this is hemorrhagic stroke. Maybe you stretch your neck and you saw someone write hemorrhagic stroke and you also wrote it. Or let's say you've made a diagnosis of infarctive stroke and you're not sure. Maybe you saw it somewhere and you wrote. Just write what you are sure about when it comes to management. Write the basic things that you know you won't get wrong. Nobody will mark you wrong for saying you resuscitate and then you come and write, you give oxygen. You come under, you give IV fluid to control this. You come under, you check vitals. Nobody will mark you wrong for that because you will do those things as well. And those things are basic for the survival of the patient before the advanced things come in. If you are not sure, write the basic things and look at the symptoms in the question and then manage it. The examiner won't give you anything less than 5/10. The least you get is 5/10. You get it, or 6/10. So for this case, for both of you, I think I won't mind giving 12/20. It's not bad. My only worry here is that you got a general case study and the examiner didn't say anything. He didn't give you a detailed question. So one, history is missing. It's not so clear. The examiner didn't really tell you about examination findings. The examiner didn't give you investigation findings. The examiner just went straight on and said, how will you manage this patient? In medicine, always know that management is what? History, examination, investigation, and what? Treatment. Okay. History, examination, investigation, and treatment. And that is how you make diagnosis even when you are doing your locum. You listen to the patient's story, then you touch the patient, then you write labs, then you write your drugs. If you get a question, just a question like that, and it's how will you manage your patient, and you see 10 marks by it or 20 marks by it, clearly, we don't want you to come and write 1, admit, 2, IV fluids, blah, 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 1 liter in maybe 30 minutes, 1 liter in 1 hour, 1 liter in 2 hours, 1 liter in 4 hours. IV soluble insulin, 0.1 international units per blah, 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 blah. Give potassium because of this. If it is 10 marks, you get 5 because you've listed treatment protocols. But have you managed the patient? You haven't even told us what your diagnosis is. Because I didn't give you diagnosis in the question. I was expecting that you tell me that, well, from this history and from the sugar being high, we'll take further history, blah, 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 and you bring it down. Then I'll examine patients, blah, 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 blah. After history and examination, I would be thinking of, then you put it there, maybe diabetic ketoacidosis as my main diagnosis, and also HHS as a differential diagnosis. That's how you answer a question like that. So you tell us the history. You don't have to write a long page. You can just write some small paragraph on the kind of questions you ask the patient or the patient's relative. Do you have a family history of diabetes, blah, 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 all those things. or have you been diagnosed? Because sometimes you ask patients, are you diabetic? Patients will say no. Then you ask patients, have you been told in the past that you are diabetic or your sugar is high? Have you done any investigation in the past that you were told that the sugar was high? So that's how you take the history, because you realize that most patients who will come in will tell you, I'm not aware I have sugar problem, but then most of them have been told and they have decided not to take medication and to resort to other means of care. Okay, diet and whatnot. Diet is an important aspect in managing diabetes, but if your sugars are that bad, only dietary input won't help you. You need diet, you need exercise, and you need treatment protocols. So history is important. Examination is important. If you so happen to get a question that gives you a history, gives you examination findings, and even tells you that urine RE done showed that ketones were 3 classes, that one, clearly they've given you the history, examination, and some investigation. So the question would say, they will be more specific. What is the clinical diagnosis? Okay, what is the pathophysiology behind this condition? Blah, blah, blah. What are some other investigations that you can do? How will you manage the patient? And that one, you know that because we've given you history examination and in the question, we've even asked you about investigations, you just tell us about treatment protocols. Are we okay?
Yes, sir.
Okay. So in your licential, any exams that you see, if you see just one question, how will you manage the patient? Know that it's an essay. An essay, you won't bullet or you won't write 1, 2, 3, 4. You write an essay, so you write it in paragraphs. So your first paragraph can be on your history. Your second paragraph can be on examination findings. Then your third paragraph, after you've written your examination findings, you can say that for the history and examination, these are the diagnosis or the differentials that you have. Then your other paragraph will be on the investigations that you do for the patient. Then afterwards, your last paragraph will be on the management for the patient. Even though it's an essay, if you take it session by session, you can bullet the point out. Just make sure that all the sessions appear from history, exam, investigation, and management. Okay, but if the examiner wants to be nice, he'll give you history and some examination findings and some investigations, and then ask you simple questions on that. And those ones are straightforward. Okay, so for this case, as I said, history, exam, very important. I've given you that in your slides already. Investigations for this patient is also very, very important. So this is a clear case of hyperglycemia in a DM. Now, you have to be able to tell us that depending on the way the question is set, like from what I gave you initially, if you go ahead and say hyperglycemia in DM, you get the full marks. And then if you go ahead and see that hyperglycemia in DM, you would want to differentiate, you'd want to find out if it's a DKA or HHS, even better. Okay, and of course, you put your features in there. Let's talk about DKA, which is one of the common things that you'll be seeing in the emergency. So usually your patients that will come might not know they are even diabetic in the first place, or they know that they are diabetic, but then they decided to stop using their medication. Or they are diabetic, they are using their medication, but then the whole sugar level has been triggered by a stressful condition. So maybe an infection will cause stress. Once there's stress hormones, cortisol comes in, it will push your sugar up. If you have myocardial infarction, it causes stress. Once there's stress hormone comes in, sugar goes up. So you can be taking your normal medication, but then once you are stressed, your sugars will go up. What causes DKA? Why is it that not everybody who has hyperglycemia would have ketones? The reason has to do with insulin. if you have a patient who is diabetic and is taking tablets, the reason behind this is that the patient has some level of insulin in the system. So the tablet is usually going to make the receptors sensitive to this insulin, or in a way is going to, act on the the cells of the islets, of the beta cells of the islets of Langerhans to make insulin, right? So this patient has a level of insulin. Once you have a level of insulin, it's always enough to prevent you from breaking down lipids or from causing lipolysis. For you to develop DKA, lipolysis needs to occur, and this lipolysis would lead to the production of ketone bodies. So if you have some level of insulin, you will usually not develop a DKA, but once the insulin level goes down, and it's not in only type 1 diabetes that you can be deficient of insulin. If you have type 2 diabetes for a very long time, you can hit a point whereby your body is not making insulin at all, and you become at risk of DKA. And that is why our previous lecture, I told you that you can make a diagnosis of type 2 diabetes. Don't scare the patients with, if you don't take your medication, I'll give you insulin. Because even though it's type 2 diabetes today, in the near future, the pancreas will stop making any insulin at all, and it will start resembling a type 1 diabetes. And then at this stage, you will need to give the patient insulin. So you don't scare your patients with insulin. Let them understand that it's part of the treatment. And at some point, their condition may get worse and they may need to go on insulin. So if you have insulin, you won't develop lipolysis, right? You are breaking down some, you are doing some glycogenolysis or gluconeogenesis, some appropriate sugar stores and all that. But once the insulin goes down, your blood sugar goes up. Your body feels that I'm starving, even though your blood sugar is very, very, very high. Your body still feels as if it's starving, because this blood sugar that is going up is not going into the appropriate places. It's just in the blood. Your body would say, all right, go on, let me break down lipid stores because it looks like I'm starving. You break down lipid stores, and the side effect of that is the production of ketone bodies. And these ketone bodies are basically acidic, and that is what is going to cause you to develop the acidosis. And that is where the name comes in, diabetic ketoacidosis. Okay, so straightforward, don't get confused. Once you break down ketone bodies, your hydrogen ions would increase and your pH will drop. pH will fall below 7.0. Once this happens, most of the enzyme systems will be compromised, and then you are going to have severe complications. Okay, so basically your patients would have the symptoms, because the ketone bodies itself will make the patient feel nauseous and vomit a lot. Patients have abdominal pain and all that. You might miss this and manage it as a gastritis because of the vomiting and the abdominal pain. Okay, but then with your investigations, you realize that ketone bodies are high. Clearly, this is a ketosis. There's some form of acidosis. Let me go ahead and then manage the patient. Okay, the breathing, they start taking in some form of, they hyperventilate, so they take in some form of deep breath. Okay, and that's what we call the Kussmaul's breathing. Okay, so they hyperventilate, and then the breath also smells fruity due to the acetone. Acetone is a type of ketone body. And because they are vomiting a lot here, they can go into shock. Okay. Investigations, you know what you're doing. As Anthony Bell said, BE and creatinine is very, very essential. We know our sugar levels, so BE and creatinine is essential, especially with potassium levels, because in this case, high sugar, you are going to give insulin to control the sugar. We know that insulin has that effect of forcing potassium into cells. So you rush to give insulin and your patients will end up developing hypokalemia, which will lead to cardiac arrhythmias and it will lead to death. So in your bid to go and manage the high sugar level, you'll cause another problem. Potassium level will fall, arrhythmias will occur, and the patient will die. At the same time, in your bid to prevent this possible hypokalemia, you go and administer potassium, and if you don't regulate it, patients will develop hyperkalemia and patients will die. Diabetic ketoacidosis is a dicey situation. It's an emergency, and you need to be cautious in managing the patient. It takes a lot of calculations to decide on how much potassium to give and what's not, and that's why you need a specialist to come in to help. Your own is to know the basics that I'm going to administer insulin. What are the risk factors? There's a risk of hypokalemia. How do I prevent that? I can prevent that by giving some potassium. Giving potassium parenterally, there's also a risk of hyperkalemia. How do I prevent that? I need to have regular BE and creatinine done when I am managing my patient who has a DKA. Even if possible, if you can get your BE and creatinine twice a day, which in Ghana is not so possible, but if you can get a daily BE and creatinine for a patient you are managing for DKA, it's on point. You need to do it regularly. Okay, so these are the other investigations there. The next thing is to try and find out what really triggered the DKA. Is it because patients, is actually diabetic but has no idea, or patient failed to take insulin, or patient has an issue? And that's why your full blood count, your urinary, urine CS, all those things comes in because you're looking for an infection. ECG comes in, maybe there's a pneumonia, chest X-ray comes in, maybe there's a pneumonia, ECG comes in, maybe you are thinking patient has some form of MI, all those things. So you need to get it done, right? So these are some of the complications that you can get. Because your patient is vomiting a lot, patient can go into shock.
Hello, sir.
Yes, hi.
Hello. The investigation, I saw ABG measurement. What is the meaning of the ABG?
Oh, arterial blood gases.
Oh, okay.
Yeah.
Okay, sir.
So you can also get, your patient can go into coma. Because you are going to infuse the patient with fluid as part of your management for hyperglycemia, you need to give normal saline, as Anthony said. You need to be very, 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 very cautious. You don't overhydrate your patients because of risk of pulmonary edema and whatnot. Okay. And then, of course, you need to think of complications that may arise due to your treatments, like giving too much insulin can lead to hypoglycemia, or you can have hypokalemia because you failed to assess the potassium level and you went ahead to give your insulin. Of course, you can have hyperkalemia as well due to overdose of insulin, and pulmonary edema. Patients can also get very cold, so you need to manage accordingly. Your aim is to resuscitate the patient. Make sure you are giving your IVs. Make sure you are converting the patient back to a normal physiological state, so you control the acidosis, like you basically reverse it. You make sure you are bringing the sugar back to normal. If there are any electrolytes lost, potassium and whatnot, make sure that you are giving your potassium. And then, as I said, it's very, very important that you look for the underlying cause and then you manage it accordingly. Okay. So you have the slides, you go, this is how you decide to give your IV fluid. Usually we say give 1 liter in 30 minutes, within 30 minutes, make sure 1 liter is gone. So within 1 hour, make sure you're giving about 1 to 3 liters. Then the next 2 hours, you're giving the next hour that follows, you're giving about 1 liter. Then the following 2 hours that follow, you're giving about 1 liter. Then you are giving about 1 liter again in the next 4 to 6 hours. Okay, it's very, very essential because you need to make sure the patient is hemodynamically stable. Whilst you're giving all these fluids, you are listening to the lungs. Remember pulmonary edema. Then per the patient's weight, you give 0.1 units of per kg per hour of soluble insulin, and you give it IV. You give it IV. Whenever your patient's insulin sugar level goes up, especially when you exceed 18, they will come and call you. You can have a chart, a sliding scale chart or whatever on the ward. But if your sugar goes above, or patient sugar goes above 18, the next thing is call the clinician. They'll come and call you. Sometimes you go and you're like, when the patient came, the sugar was like 28. But we've given about 4 doses of insulin. We are around 24. What's the problem? Then the nurse will tell you, we are giving it subcuts. Don't do anything in this case. Especially a patient comes and sugar is about 33.3, and then you've written your instructions, but you fail to put IV there. And the nurses usually give it subcuts, especially if you are giving your mixed-start and all those things. You give it subcuts. Then you don't indicate your IV. They'll go and give it subcuts, and you can't blame anyone. So always make sure you're giving IV, soluble insulin. You're giving soluble because it's short-acting, okay, and it goes in there, it works faster. Within 1 hour, it's done its work. You go and check the sugar again. You keep giving 1 hour, and every hour before you give the insulin, you check the level of the sugar until you get to about 11.1 millimoles per liter. Then you stop because of risk of hypoglycemia. Okay. Usually when you get to about 30 millimoles per liter, you hold on with your normal saline and you convert to DNS. But for the sugar, when you get to 11.1, you stop. Then of course you go ahead and then you check your BU and creatinine based on the level of potassium you have. You know what to do per the chart here. Most of the time, the acidosis will correct by itself. In some cases, however, we give patients sodium bicarbonate, as you can see, but most of the time it will correct. Then you can go ahead and then you look for what's caused the problem. If there's an infection, you treat with empiric antibiotics. You manage all those things accordingly. This is one protocol, but there are other protocols and some facilities administering insulin. Some people administer via the perfuser. Perfuser method is different because most facilities don't have perfusers. Some people will decide that, all right, okay, let me put this amount of insulin, maybe about 25 mils of insulin in about 50 mils of this fluid, and then let it go at this value or at this rate. We have the perfuser method, and some facilities do that. So when you go and do your clinicals and you see people doing that, don't feel out of place. They have protocols there. So you just look at per the protocol, how much insulin you are putting in the fluid, and then you are basically administering that, and then you are observing the patient's sugar every hour. Okay. I'll take your questions. I need to run, so if you have any questions, you let them come. But I would advise that you read on your strokes well, and then you also read on your DK as well. So let me take your questions before 8. Any questions, please? You don't have any questions. All right.
Okay.
So great. So tomorrow we'll meet and then go through a topic or two. Hopefully by then you should be ready for the exam. If we are unable to touch on or revise any topic, don't worry about it. It won't pop up in your exam. But it's for you to use the topic as guideline to read through the slides. Maybe you see it in your MCQ, so for you to practice in later life. So tomorrow we'll try and go through, and then you can have Wednesday, Thursday to prepare for the exam. Okay.
Okay, sir. Thank you.
Thank you very much, sir.
You're welcome.
Have a good night.
Thank you. You too.
Thank you, Doc.
Okay.
Okay, bye.